I would like to announce the next session. We are delighted to have with us, okay, let's make sure I pronounce Fred's name right, because I always struggle with this. My Dutch just isn't up to much. So, Professor Fred van Einenam. How did I do? Okay, perfect. We are so fortunate to partner with the Value-Based Healthcare Prize each year, and Fred is going to meet with the winner, Susan McKee. Fred is the chairman of the Value-Based Healthcare Centre in Europe and is a great friend of ICHOM's. So I'm delighted to welcome Fred and this year's winner.
Okay. So thank you very much. It has become a yearly tradition that I can announce sort of the VBHC prize winner of the year, and then that winner will do a short presentation for us here and hopefully help us think and inspire and move forward on that. So that is what I'm honored and pleased to do. Value-Based Healthcare Centre Europe, as am I, has been since 2008 been sort of madly focused on how do we implement. So I'm an implementation guy. So how do you get it done? Well, we heard so many hurdles during the day, but people do it. And you can get it going, and that is what we find very interesting. We have yearly the Value-Based Healthcare Prize. We also have yearly the Dragons Grant, and there's a couple of cases and other things that you may find interesting if you have the time to scan through at a certain point. We have around 1,253, let's say, proven successful implementation of value-based healthcare. So when people tell me, can you implement it? I say, that's not the issue. It may not be the easiest thing in the world, but it can be implemented, it is successful, and probably in your field. Here you see a list of the prize winners on the top, and there are many people that won awards, and they all have a great, great story to tell. We do not only have the Value-Based Healthcare Prize, but we also have the next generation. And if you have the time, I strongly encourage you to do that. It's called the Dragon Grant. We have people in a friendly competition who have a great proof of concept of what we think, if this is going to be implemented, wow, that's going to be the future of value-based healthcare implementation. And we also have some groups that are close to winning the prize that we're also helping, and we're really helping them, writing letters, calling their bosses, saying they really need support because they were going to be very, very good. So that is what we do, and actually I must admit, we learn a lot from the great ideas that doctors and teams and nurses have every year. So I also got the question, since it's the 10th year of ICHOM, and I really applaud the effort and really proud to be on board from, I think, day one, and to collaborate over the years. Are there some of the wishes you have, Fred, that we could collaborate or that you think is important for everybody to move forward as a community? And I sort of checked with a couple of people, and I basically have 3 wishes. Number one is that we really start seriously educating the next generation of health administrators, doctors, nurses, everybody there, and that we bring in VBHC in the curriculum and specifically pay attention to the fact that we want doctors and teams to embrace wanted variation, right? So there's a lot of pressure of reducing variation because, of course, there's waste and things like that, but we must focus also on wanted variation and being really good at this, at the patient and the personalized level. The second thing is I think we have an issue in many countries to sort of tackle this budget cost mentality that we see coming from the top down, and just have a friendly but stiff and strong conversation on, but what's patient value? Stop cutting small costs from the top down, start focusing on patients, and you'll see that if you focus on outcomes, most of the time your costs will really go down. And thirdly, and this may be only a Dutch thing, I don't think so, but if you are in my country a doctor, and you want to lead a team and you want to implement it, and you want to do a little bit of quality of life and a little bit of mental health and a little bit of that, you have to deal with 5 different laws, with 5 different compliance structures, with 5 different payment structures, with 5 different inspections. So I think we really need a cleanup in untangling rules, regulations, and systems, and really get it back to what it was intended for the people and the patients, and not for anything else. So those are wishes, maybe for the next 10 years. I hope it's not going to take 10 years. I'd like to announce the winner of this year, and it is Dental Health Victoria from Australia. Really proud of that. It's in dental. Susan McKee is that, and why did she and her team win? And she's going to talk about it much more than I can. But of course, the effort ticked all the boxes on value-based healthcare. It had great outcomes, it measured it carefully, it had great medical conditions, it had stratification, it involved the patients and their families, incredibly great on data, great on IT, great on outcomes, great on learning, and I assume great fun for dentists, okay? What we found the most intriguing one for the really extra plus of dental are two things. Number one is for 300,000 people, and they have excellent dental care. And not only that, it is in one of the most severe capitated models in the world. NHS Australia doesn't sound like fun. Within the capitation model, having great outcomes, making sure that everybody gets their dental care very well over time, and doing what we found great is get rid of co-payments. Co-payments are most of the time not what we want. So basically what dental health shows, if you focus on outcomes, your cheapest patients are healthy patients, and not wait until it's really a dental problem. So that's what we found interesting on the scale and how they collaborated with the system. Before I hand the floor, I just want to make sure that actually all the award winners and all the nominees of this year are very close to my heart. And I think many of them would have won the prize 3 years ago. That is how fast I think the implementation and the growth goes in terms of value-based healthcare implementation. So please, if you meet them, bow for them, applaud for them, and listen to them and see if you can help them move forward. I'd like to thank, of course, the people, including ICHOM, that helped us so tremendously finding the right applications. I hope you will think about bringing in applications. It's going to be at the 10th of May. You're welcome in the Netherlands. It's then great weather, believe it or not, it's great weather. You can do it online, or you can later see it on videos. Or if you're there anyway, the day before, see the future of value-based healthcare in terms of implementation. So without further ado, you can reach me if you want to. I love to hand the floor to Susan McKee. And Susan, please inform us why you got so excited about dental care and took all the efforts in to make sure that Dental Health Victoria would be so amazingly good. Go ahead, Susan.
Thank you, Fred, and thank you for this fabulous opportunity to be here and speak with you. And thank you for, I guess, the honour of actually receiving the Value-Based Healthcare Prize. So if we can flick to the next slide, please. So just a bit about Dental Health Services Victoria. We run the public oral health services for the state. So we have about 6.5 million people in Victoria. About 2.5 million of those are eligible for public dentistry. And as Fred said, we only get to see about 300,000 of those. So our aim is that we actually end up having a Victoria that is disease and cavity free, a very big vision for us. But because we actually have the whole system within our control, so we actually run dental services, so we run services through the Royal Dental Hospital of Melbourne. We do the population health piece around health promotion and how we actually do that. We teach all of the new dentists in collaboration with the universities here in Victoria. So the new dentists and the new oral health therapists all come through our system to be trained. And we actually commission over 50 agencies around the state to do public dental services. So we have all of that within our remit. So it means that we can actually look at value-based healthcare from a system level. Next slide, please. So obviously we took Michael Porter's value equation, the outcomes that are most important to patients over the cost of delivering those outcomes. So we're looking at value from that very simple point of view. Next slide, please, Fred. So what we did at Dental Health Services Victoria is actually built a framework around value-based healthcare. We took Michael Porter's 6 elements and we added some elements to it, particularly around that patient and staff co-design and engagement, making sure that everything we do has our patients and our staff at the centre of it, actually making sure that we're delivering the care that we should be delivering. We also added in we added in a couple of other things because we knew implementation wasn't just about having a theory. It was actually how do we actually improve the capability and capacity and culture of our organisation so we actually have an organisation that's ready for change and wants to continually transform. So we added that into our framework. We also looked at infrastructure because we actually run what is called the Smile Squad here in Victoria. So it's the school dental program, and we have lots of dental vans out around the state going to schools to deliver care. And we wanted to make sure that those that infrastructure was actually fit for purpose, and it was actually there and designed really clearly around our value-based healthcare model. Next slide, please. The other thing that we did, we also looked at value-based healthcare as a set of principles. So when we first started talking about value-based healthcare, people thought it was a new shiny thing, a new thing to do. And they were talking, well, you're just adding more work and putting that on top of what it is that we already do. So we actually changed our language around, it's not actually a thing, it's a set of principles by which we actually make all of our decisions. It's a set of principles by which we actually look at the way that we deliver care. So we actually looked at care it's around the patient. So that IPU concept, about making sure we've got the right care being provided in the right place by the right person. So making sure that all of our staff are working across their scope of practice. So making sure that oral health therapists are doing the things that they can do so that dentists can go and do the things that they need to do. We looked at it from a prevention and early intervention point of view because oral disease is as a disease that's mostly preventable. So it's about how do we make sure that people understand how to prevent poor oral health. We're making sure the care is integrated and coordinated across the system. And because we actually look at the whole system, we can see how that happens. We want to continuously measure and utilise that measurement to improve. And as Fred said, it's about reducing unwarranted variation. There needs to be variation because we're all human, we're all individuals. Something's going to be slightly different about me compared to somebody else. So it is important that we're looking at unwarranted variation, not just variation in general. And we want to make sure that we actually use our resources as efficiently as we possibly can. So next slide, please. So what have we done? So what did we achieve and why did we win the Value-Based Healthcare Prize? So we've built the framework and the set of principles, and it guides the way that we make decisions. It guides the way we deliver new and develop new models of care. We developed with ICHOM the oral health standard set. So we have a standard set of outcome measures. We spent a couple of years with ICHOM actually building that standard set. We use that in a variety of ways. So we use it to measure outcomes that are important to patients, which obviously is an important part. But we also use it to stratify our wait list. It helps us understand the complexity of individuals and those who need more support and more care compared to those who actually have good oral hygiene practices. It also helps us with shared decision making with the patient. So we use it as a tool for our clinicians to actually be able to have those conversations with patients. So for our patient cohort around oral health, the things that are important to them is, can I eat? Can I sleep? Can I smile? Those are the sorts of things that are important from an outcome measure point of view for our patients. We've implemented 2 new service delivery models, so around our school dental program and also our adult dental program. We've decreased funding for low value care. We haven't been able to get to the point yet, but we're working on it, is how we actually have a funding model that enables us to fund for outcomes. But what we have looked at is those things that we think are low value, and we've actually decreased the price that we pay for those. And we've looked at things that are high value, like education and oral health, oral hygiene education, and actually increased the value that we pay for those. So we're slowly moving the system because we know that funding drives behaviour. We're building workforce capability and culture to make sure that people who are coming into the system actually understand value-based healthcare and how they can actually implement it. And we're utilising technology to streamline processes and build data tools. One of the key things that we do need to continuously improve is how do we actually make sure that the data that we have is being utilised to show that we are improving the system. So Fred, that's all I have to say. So that's what we've been up to here in Victoria.
Okay. Thank you very much, and let's have a round of applause. So we have some time for questions, and I never heard somebody who didn't have a co-payment go for fun for the dentist. So maybe a question. If somebody has a question here, that would be fine. Otherwise, I'll start off with one. Susan. we really applaud this. If you look back at how did you convince the people at the NHS to sort of accept your approach moving forward? Why did they become supportive instead of questioning you?
They continue to question, so
yep.
it's not without challenge, but we actually built the system and actually went and explained to government what the system would do and what would be different and how that would actually help them. So at the end of the day, the bucket of money that we get is still the bucket of money that we get. It's just about how do we actually see more people. And they were really keen, if that was the outcome we were going to get, to be able to see more people and improve oral health, they were 100% supportive of us. They gave us a small grant in the beginning to actually start the process and actually do some pilots and proofs of concept. So they were really, I guess it was the previous CEO and the previous board chair that were very convincing for government to let us have a go at this and see if it would make a difference.
Okay, so you took away that risk. I'm just checking if there is a question. I cannot really see it in the light. We're still all so impressed and thinking about our smiles that we're not that sure. I always get a question when I use your case in some of our teaching or other things is, what is the Smile Squad doing? Is that a sort of a police, or what is it that they do?
So the Smile Squad is our school dental program. So we actually have a variety of different models that actually go into our schools. So the model of care is basically very similar to the one that we use in our adult population, but it's about assessing the children. It's about using the outcome measures to understand those kids that are most at risk. So we actually have some mobile equipment that goes out. So we have a van that's bright orange and it has a team of clinicians in it, and we actually go out to the schools and do assessments with all the children. And then if they actually do need dental care, we either bring them into one of our fixed clinics or we send an actual dental van with a dental chair in it out to do that care.
Okay.
And so the government has increased our funding. So they're wanting us to see every child in every public school, both primary school and high school here in Victoria. So about 650,000 children that they want us to support. So that's a massive increase in the workload for us, and finding staff to do that at this point in time is interesting, but it will make a significant difference to that cohort of kids in Victoria who will all have an understanding of what good oral health is, but also will have access to those highly trained clinicians.
Okay, great. Okay, I'm just checking. Yes. Can you find the microphone, or otherwise I'll try to put that forward.
This is really fantastic work, so congratulations. I guess my question is that I'm not an expert on this subject, but my understanding is that really good oral hygiene and dental care is incredibly important for non-dental outcomes and chronic illnesses and diseases. And in the United States, we actually have a very severe problem with people who do not get the dental care they should get that's contributing. I'm wondering if the ICHOM sets are sensitive enough for you to actually see if you've improved non-dental population health by your oral health fantastic program.
You got the question, Susan?
Yeah, no, thanks, Fred. I got that question. The ICHOM standard set that we use is all about oral health. And it doesn't actually then link to whether people's diabetes is better controlled or their, heart disease isn't getting worse because they've improved their oral health. But as part of, I guess, the longer term process would be looking at those other medical conditions that are impacted by people's poor oral health. We haven't got a process for that at this point in time, but there's lots of evidence that we know that if you improve your oral health, you improve your overall health across generation.
Okay, so that was one of the reasons why we're quite impressed. I learned a lot from what it does psychologically in your digestive system, in your self-esteem, in going to work. There's a lot of things, and it seems to be captured. and not only captured, but also implemented over time. So that was quite impressive. Great question. Other curiosity? Yes, go ahead, sir.
It's a fantastic story, so thank you. If you were winding the clock back, are there things that you would do differently if you were putting this in place again? Either places where you underestimated a challenge or missed something, or places where you invested a lot of time, effort, money that turned out to have a lower return? Because many people, I'm sure, are thinking about what they could do to implement in their own spaces, in their own specific disease areas.
Thanks, great question. If we could turn back the clock, we would probably spend some more time planning before implementing. We tried to boil the ocean, so we tried to do a lot very early on and realized that, you can't implement this kind of transformational change overnight. I think one of the things that we would do differently is actually change our language earlier. So like I said, we actually talked about value-based healthcare as a thing rather than a set of principles. And once we started talking principles, you can't argue with the principles. Every health practitioner on earth would go, absolutely, that's what we need to do. So it's actually being able to have those conversations at a different level with our clinicians, so that, when we first started, we talked about we're going to start doing person-centered value-based healthcare, and they're like, but we do person-centered care, Sue, what are you talking about? And they got quite upset with us. And it's actually, yes, you do person-centered care, but this is when we talk person-centered in value-based healthcare, this is what we actually mean by that. So I think those sorts of things would be different. The other thing, we got the ICHOM data set, but we actually reduced it quite drastically in our use now. So we've actually got a much smaller number of questions. We actually co-designed that with our consumers to really understand what's important to them, and actually used a much smaller set of questions in the end than we did in the very beginning. We were using like all 23 of the ICHOM questions in the beginning, and our patients got quite confused. So those sorts of things were really great lessons to learn. So if we wound back the clock and we knew what we know now compared to what we knew then, we'd probably do a few things differently.
Okay, great question, thank you. Other questions? You now look at your dentist differently next time, okay? Mm-hmm. I have some, if I have some time. Maybe, Suzanne, I was quite impressed with how you involved patients and their family. Could you elaborate a little bit on how you involved that and how your team learned?
Yeah, so we co-design is one of those things that was quite novel when we first started. So we actually had a co-design expert come and work with us around what that actually means. So as clinicians, we think co-design is we'll build something and then we'll ask the consumers whether it works for them. And that's not co-design, that's just asking consumers their opinion. So we actually had to work really hard around building our consumers' capacity to co-design and building our staff's capacity to co-design. So now we actually go to our consumers with a problem. This is the problem we're trying to solve. Can you help us solve it together? Rather than, we had a problem, this is what we think the solution is, what do you think about that? So it was a long journey for both our consumer groups, but also with our staff to actually understand that and how we build that into our systems from the very, very beginning. We do now have 3 quite large consumer networks within our organisation, one around our school program because it's new and we're actually building things into that system. We've got one around our general oral health care that we provide, and we also have a subcommittee of our board, which is our consumer advisory committee, who actually work really closely with us on a lot of the items that we're building and generating. So it's been quite a long journey for all of us, but it's now really embedded into everything that we do. And it's about not just about our consumers, but also about our staff and how they can actually support the co-design of the work that we're doing.
Okay. Other questions here? Otherwise, I have a final one, is what are the dentists want to do next? Because you now won the prize, and I cannot see a higher honor personally, but maybe. But what's going to be next with your team of dentists, which I know are working at the top of their license? That's what they told me, But what are they going to do next?
So I agree. It is the highest honour that you could possibly have, and particularly, you know, being given the prize by actual Michael Porter himself was actually the highlight of my year, and really important for our staff and team to understand how the work that they're doing is truly making a massive difference to not just our consumers, but actually the global community as well, which was really important. I think the next steps for us, there's a couple of key pieces of work that we're doing. One is around the funding model. Can we actually build a funding model that actually funds for outcomes? So we're talking to our Department of Health around what that might look like. We've got some new IT platforms that are being implemented. So that's a massive piece of work for the whole state. So we will have one IT platform with all the patient information in it, which will be so exciting to be able to track variation and track those patients over time. And the other thing is we'll continue, we've got a couple of service delivery models that we want to build, one around early childhood, and one around elder care. So there's some more models that we need to build and test. And we also just need to keep doing the work that we're doing, because this is a long journey. We've been doing this for over 5 years now. That's one of the other things that we have learned, is that there is no end to this. You actually just need to continuously improve. So we've got a lot more work to do yet, Fred.
Okay. Well, Suzanne, thank you so much for your time, and we wish you a good last part of the night in Australia, I think. But it was wonderful to have you here, and I'm sure that people will be interested and get inspired. So thank you very much, and hope to see you soon. Thank you.
Thanks, Fred. Thank you, everyone.
And for all of you, you can do better, right? So I'm looking forward to your applications and hope to see you in Amsterdam. Thank you.
That's wonderful. Thank you so much.